Hello everyone, my name is Hassan Maghaireh. I'm very happy to share with you my lecture, which will focus on management of advanced cases in implant dentistry. I will share the screen now. So yeah, it's a great honor to be here with you today. And in today's lecture, we're going mainly to focus on advanced cases in implant dentistry. And when we talk about advanced cases, according to the ITI classification, we have simple, which are the simple cases which do not require any bone management or soft tissue management, and patient expectations are very low. And then we have advanced cases, and usually these are cases in the anterior region. And we've got complex cases such as full arch restorations and etc. So for today, in this lecture, we're going to focus on cases in the anterior region. Hence, we're talking about advanced implant cases. I'm very proud to be the head of the scientific committee of the British Academy of Implant and Restorative Dentistry, which is based in Leeds in the United Kingdom. But we are active and we run implant and restorative courses in the United Kingdom and all around the world. I'm also associate professor at the College of Medicine and Dentistry of Ulster University in Birmingham. I'm associate professor in oral surgery and implant dentistry over there. And I'm also clinical lecturer in implant dentistry and examiner at the University of Manchester. So we'll be talking about dental implants. But the thing is, you could go ahead and have an implant placed. And while in the past, the challenge was all about osseointegration, the implant integrating or not. Nowadays, we do understand that integration is not good enough. You need to focus on the bone management and the soft tissue management as well. And not only the management, but also we want to have a long-term stability. Now, it's up to you. Do you care about this or not? It's up to you to decide whether you're going to be happy and comfortable with having implant cases like this or not. Are your patients going to be happy to have implant cases like this 5 years on the line or not? Are you going to care about it or not? Are you going to be an average implant dentist or someone who wants to be above average? An average implant dentist will mainly focus on integration of the dental implants and success of the prosthesis. But this is not good enough nowadays because, like it or not, our patients will expect some cosmetic results, aesthetic results when it comes to dental implants. The gum is also important. You need to have successful, healthy gum to provide good protection. So while some people will just focus on trying to deliver implant cases as quick as possible, as cheap as possible, and make a profit, I think you and I need to be focusing on the long-term success of implant dentistry, especially when we talk about advanced cases. Well, we teach at the British Academy of Implant and Restorative Dentistry, BAIRD, that every dentist needs to be above average because average is not good enough. And we have a duty to work hard to be the best we can be. When it comes to implant dentistry, my friends, the best achievement is going to be to do with your passion. And the opposite to passion is being indifferent. I strongly believe there isn't a bad dentist, but there is a passionate dentist who focuses at every single step in the treatment journey. And there is someone who's just indifferent, doesn't really care if they cut corners or compromise the final result. When it comes to passion in implant dentistry, I think we're talking about pink aesthetics. And pink aesthetics is a multi-system components. Basically, we're talking about the labial convexity because we understand without that convexity, that implant gonna look fake. We're looking at the zenith and we understand that the zenith of different anterior cases is gonna be different. You cannot have a circle zenith for all different cases. And it has to be matching the corresponding teeth. The same thing goes for the emergence profile. The emergence profile of a central incisor is going to be completely different to emergence profile of a canine or a premolar. And we would like to have a good soft tissue level. And obviously, we would like to have a good papilla because we don't really like black triangles. Unless the patient is smoker, then you are basically in a dead end situation. The color and the texture of your soft tissue are also important. At the end of the day, we need to achieve beauty and strive for success in implant dentistry. We want to provide something which is beautiful, but also quality, high quality, and reliable on the long term. And we understand from Professor Erzbelzer in Switzerland, you really need to focus on pink aesthetics first, and then white aesthetics become really easy. And these things don't happen by coincidence. You have to have a system to follow, as you will see later on, to help you to achieve success. Now, I could show you how to do it, but I think it's more important is to understand why we're doing this. And whenever we ask the question why, surely the answer needs to be based on evidence-based data and sound understanding of oral biology. So what we're going to talk to you today about how you can integrate surgical and prosthetic strategies together in order to achieve happy and great results, happy patients with great results when it comes to implant dentistry. You need to understand the challenge, and then you need to have a philosophy to follow. And this philosophy will control what outcome you want to have. Some people are happy to have average outcomes or below average outcomes. It's up to you to decide, are you going to be part of that group or not? Depends on your philosophy. And then you need to have some guidelines, clear guidelines to follow. And after that, you're going to need to put everything you know into clinical perspective and start with your hands to put in reality what you've learned. And today we're going to cover some clinical cases to show you how we're going to deal with that. What's our outcome? The outcome is we want to achieve harmony. We want to have our final natural results matching the other natural teeth. So we want our implants to mimic nature as much as we can. And this is the challenge. The problem is when you start, you always start from square minus 10. You know, whenever you have a tooth out, you're going to have some bone loss. We know, depends on the phenotype of the case, and the phenotype, basically, we're talking about the thickness of the gum and the bone underneath. You can have up to 20% bone loss in the first few weeks if you have a thick phenotype, but that goes up to 50% bone loss if you have thin phenotype. We also know that when sometimes teeth are taken out with the trauma, it's going to damage that labial plate because that labial plate usually is very thin. 87% of the cases, the labial plate will be thinner than 1 millimeter, so it can easily crack and break if you're not careful. One can also appreciate that failing postcrowns usually going to be associated with labial bone loss. So whenever you have a failing postcrown, try to look at that root. If there are vertical splits, there is no point of trying to re-cement that postcrown. And sometimes taking the teeth out will be as quick as possible will be the best thing to do. Now, once you want to deal with this case, you need to do a proper space analysis. You need to look at the buccolingual, which is important, but even more important, the mesiodistal spaces. And you need to be focusing whenever you place two implants adjacent to each other on that bone in between the two implants, because this bone is going to support the papilla in the future. And here we need to make a decision, what implant size we need to go for. In the past, we used to think the bigger, the wider, the better. But now we understand that's not the case. So we would prefer to have narrower implants in the anterior region so we can have more space for the bone to go in, the new bone grafting we're going to perform, but also to maintain that interseptal bone between the two implants. But how narrow we can go for will depend on the type of titanium you're going to go for. We know that type 4 titanium, which is considered commercially pure titanium, is not going to be as strong as type 5 titanium, which is the alloy titanium. Now, the problem with these alloys that you're going to have extra material added to them, and this might affect biocompatibility. However, what I like about these implants that they're made of rock solid, which is an alloy made of titanium and a very good other bioinert material called zirconia. So zirconia and titanium together increase the strength of these implants nearly by another 50 to 60%, which makes it easy for us to go for narrow implants, 3.3 in diameter, even for central incisors. But the advantage is here that you're going to preserve more bone in between the implants, and you're going to create more space for the bone grafting to go into. I personally don't like to use cover screws, even when I'm going to bury my implants, because we like to use healing abutments, and this healing abutment basically going to act as a post supporting the membrane on the top, and together going to have the umbrella effect. I've published lots of clinical cases and data on that. Please go and check my Instagram if you like. You can have more information about the umbrella technique. Now we need to do GBR, and as you all know, whenever we do guided bone regeneration, it's all about having a well-stabilized membrane. And what I mean by that, that this collagen membrane, which is a dissolvable membrane, needs to be stabilized, usually by 3mm titanium pins, tacks, or by some sutures. I find the pins easy to use because they're gonna go inside the bone, support the membrane, and then you could lift the membrane back just like a curtain and then do your guided bone regeneration. When I do my guided bone regeneration, we like to go into layering technique. We don't like to use cow bone xenograft touching the exposed threads. Having said that, we would like the xenograft to be in the outer layer because this will provide the ridge contour and the stability for that convexity we talked about earlier on. So what we would like to have, having some autogenous bone chips covering the implant surface, because these autogenous bone chips ideally will convert into new vital bone. And that is important to be covering the exposed threads of our implant. If you cannot have enough autogenous bone, then the second best will be using allograft, bone taken from the human tissue bank. Especially nowadays, we use allograft from live donors. And this will also convert 60% of it into natural bone, while xenograft 12% after 6 months' time. So allograft 60% after 24 weeks, while xenograft mainly 12%. We have good data now showing that if you cover your implant threads with xenograft, there'll be high risk of peri-implantitis. And as you can see in the bottom right photo, we tent the membrane with the healing abutments to get this umbrella effect, and then we lift the membrane and stabilize it, and then we suture nicely under no tension. It's important to make sure that the flap is closed under no tension, and sometimes we need to do some mucoperiosteal release to bring the flap back to where it needs to be. And then we leave it 12 weeks in the maxilla, after which we do tiny little exposure using punch technique because we've got loads of keratinized mucosa here. And from there, we take an impression and we make a screw-retained temporary for each implant. So in this case, 2 screw-retained crowns. These screw-retained crowns act, number one, as our test drive before we do the final. We check the shape, the color, the texture, everything. But we also use them to help us to mature the gum and help the gum to contour nicely and for the papilla to grow. Because no rigid, stable contact points means no papilla. And more importantly, we use them as our spare tire, which I mean by that, basically in the future, if the final restoration needs repair or needs to go back to the lab for one reason or another, you're going to have these temporary crowns ready to fit them in patient's mouth, rather than the patient having a gap or going back to a denture. It's important for the papilla to grow into this black triangle you've created between your temporaries. So don't suffocate your papilla. Make sure that there is a space in the contact area like a triangle, and this needs to be well cleaned for the papilla to grow into. And then from there, you could leave the temporaries for about 6 to 8 weeks, sometimes longer, to shape the gum the way we like it. But as you can see from the top right picture, we've got a nice convexity, which we managed to build, although these implants had labial defects at the beginning. Now, we've done great work with the zenith, with the subgingival profile, with the emergence profile. We have to transfer this data out to our lab technician. And we do that by customizing our impression pickups. To customize your impression pickups, you get the impression pickup basically, and you fit it to an analog implant replica, and then you take an impression and to the implant replica, and then you take an impression of the subgingival profile of your temporary crown. By doing this, you sort of get this nice impression pickup with composite underneath around the cervical margin. So how we do it again? We get, first of all, we get the implant analog, and we fit the temporary crown, the screw retained, onto the implant analog. And you take impression of the cervical 1/3 of the implant analog using silicone or Imprigum. Then once the impression sits hard really well, you remove the temporary crown and you end having an implant replica with an impression space around it. You fit the impression analog into the implant replica, and that space you fill it with composite. You build the composite layer by layer like curate, and then another layer, another layer. And then once the composite sits hard, you remove the impression pickup from the replica, and you're gonna have an impression pickup with composite subgingival profile, 100% match of the subgingival profile, your temporary crown, which is 100% match of the soft tissue emergence profile. And then from there, we've got the final restoration, which was cement retained, and we had CAD/CAM abutments, and that's how the patient finished his case. 5 years down the line, the patient changed his mind. He decided not to have that diastema between the implant crown and the adjacent central incisor. So our team, we've done a nice composite filling on the adjacent central incisor, and in no time, that papilla started to creep down. But more importantly, you could see here how that convexity around the implants on the right-hand side were completely matching the convexities we had around the other natural teeth. So learning point from this case, it's all about implant positioning. The major mistake someone can do is putting an implant too labial. In case 40% of aesthetic failures were due to implant being tiny bit too labial than the correct position. You need to place an implant as palatal as possible within a socket, because this will create space for you to fill the bone where it needs to be. We do not need wide implants in the anterior region. That space needs to be split between the implant and the bone rather than filled completely with implants. But if you're going to use narrow implants, please go ahead and place titanium type 5 rather than titanium type 4. Interesting, we know now that if you use 3.5 titanium type 4 in the anterior region, there will be high risk of fracture. And most of the fractures were found for implants with diameter below than 3.75 if you use normal titanium type 4. However, if you use titanium type 5, you're going to get a rock solid effect, and this will give you strong implant. Maintain interdental bony peaks, because these are important to support the papilla. We know the papilla depends on the distance between the interdental bony peak and the contact area. But that distance depends on which papilla we're talking about. If it's papilla between two adjacent teeth, you can get away with full papilla even if the space is 5 millimeters. While if this papilla was between two implants, that space needs to be maximum 3.5. Otherwise, you're going to get short papilla. implant and adjacent tooth is 4.5, for example. Membrane stabilization is very important to get a successful guided bone regeneration. And provisional restorations are also very important to get you what we call soft tissue sculpture. By doing this, you convert the emergence profile from a circle into the custom-made emergence profile by gradually displacing the soft tissue rather than putting too much pressure and necrotizing it. And as you displace it, you increase the volume of that labial soft tissue. The contact point is very important, as I mentioned earlier on, if you want to have a good papilla. All what we do is all about creating perfect illusion. And that perfect illusion of soft and bone needs to be maintained over time. So the challenge whenever you have a patient coming to you with a missing tooth wanting to be replacing this with a dental implant, you're going to have the patient trying to put pressure on you to try to do everything as quick as possible, with fewest possible number of surgical interventions, less pain, less healing time, and less overall treatment time, which is important and is nice. But I would like you, please, to take in consideration that we should consider these as our secondary goals. Our primary goals should be all about the success of that dental implant and the stability of the bone and the gum. Time is important, but shouldn't be our major factor. Now, in some cases, we could go ahead and do immediate placement and immediate loading, as in this case, providing we can place an implant in the correct position. And usually in immediate implant placements, we like to use longer implants so we can get stability from the bone apical to that socket. We don't want to use very wide implants because the stability of the implant should come from the apical 1/3 and not from the coronal 1/3, my friends. If you manage to get a torque higher than 35 Newton centimeter, and this should be measured using the manual torque wrench, not the motor, because the reading in the motor won't be accurate. If you manage to get this high torque, you could get your temporary abutment and build chair-side temporary crown, and you go for what we call immediate loading. Now, studies show that if that temporary crown in full function or out of function, in full occlusion or out of occlusion, no difference, providing we don't get any destructive lateral interferences. So in anterior guidance, you want to make sure that there are no interferences. Otherwise, the crown can be in full function on centric forces. Obviously, we need to do bone management in this case, and the sequence would be place an implant. If you manage to get high torque, place your temporary crown, and then do the bone and the soft tissue management. And then from there, the soft tissue gonna contour around the temporary crown. So you're gonna create everything right from the very beginning, and you get your final restoration. And you can see here, from tooth to tooth within 60 minutes. Postop CBCT showed us we've got 2 millimeter bone, which is the absolute minimum we need for the bone to stay stable. So learning points, when you go for immediate implant placement, please go for longer implants rather than wider implants. We avoid wide implants in immediate placement because we don't want to put any pressure on the labial surface of that bone. Immediate loading can be done and it's safe. There are lots of good studies and very strong evidence-based data tell us if you get 35 Newton centimeter for a single implant, you can do immediate loading with confidence. But obviously you need to design the temporary crown in the good way. Subgingival concavity is a must. And then you're gonna need to create space for bone and soft tissue in that area. Now, in another cases, patient can come to you already taking the tooth out a long time ago, like in this case. You place a dental implant and you get the high torque. So there is nothing stopping us going from immediate loading, providing the implant placed in the correct position and the temporary crown is designed with that subgingival concavity. As you could see on the middle row, the bottom, the right-hand side picture, you could see that subgingival concavity. Now, although here there were no exposed threads, I still went for GBR because I wanted the GBR to build my convexity for me, which is important when it comes to pink aesthetics. So here we went from a gap to a tooth in 60 minutes, and you could see the Postop CBCT. Learning points: having taper implants helps you to go for higher stability with less drilling. So I used to go for cylindrical implants a long time ago, thinking this will give me better bone implant contact area. But nowadays we understand this is not very essential. What's more important is to drill less and getting better stability. And that's something you can achieve with taper implants. Whenever someone has a tooth removed, as we said earlier on, you can have up to 50% horizontal bone loss, especially if we have thin biotype. Placement of the implant needs to be following the reverse treatment planning protocols. Basically, you decide where the tooth needs to be and then place the implant within that prosthetic envelope. In the anterior region, not only needs to be in the prosthetic envelope, but also underneath the cingulum, so we can have a screw retained restoration. We should always have screw retained restorations as our plan B. When things don't work well for one reason or another, we can accept a cement retained restoration. But we don't always do immediate placement, immediate loading. Because in this case, this guy had a tooth removed. We like to leave it about 8 weeks to get good soft tissue maturation and any remnants of the bacteria to disappear. And most of that bone remodeling would have taken place, so no other nasty surprises later on. We like it 8 weeks in the anterior region and 12 weeks in the posterior region, and we call this early placement. And according to Cochrane systematic reviews, that's the safest protocol you can have in your practice. You place the implant within the correct position, within the correct prosthetic envelope underneath the cingulum, and most likely you're going to have an apical perforation or cervical dehiscence. That's normal. We build the bone, as we said, in layers, stabilizing the membrane, and then if you cannot achieve 35 Newton centimeter, like in this case, we achieved 25, we go for a healing abutment. But that healing abutment needs to be narrow because we want to encourage more keratinized mucosa to grow around our implant. And then using the temporary crown, we do the prosthetic soft tissue sculpture by displacing the soft tissue. And if you compare the picture with the circle emergence profile on the middle row with the picture of the final emergence profile in the bottom row, you could see how we've got better emergence profile, but also better convexity by displacing the soft tissue using our temporary crown. And then from there, we managed to get a nice final restoration, which is screw retained and matching the adjacent teeth. This treatment took us more than 32 weeks. And that's normal because, you know, as long as you give a patient full information what's happening, and at certain time you give them a good temporary crown, patient won't mind waiting. Learning points. Early placement is considered, according to so many very good quality research, the most predictable and the safest option when it comes to timing in implant dentistry. We like to use narrow healing abutments rather than wider healing abutments in the anterior region. Always grafting and layering technique, as we explained earlier on, and the membrane needs to be well stabilized. No membrane stability, you're not going to get good guided bone regeneration. We did talk about the secondary goals, and that's mainly your patient putting pressure on you to do things as quick as possible. But let's remember, 5 years down the line, what really matters is not the time as much as the success, the predictability and the stability of the bone and the soft tissue around your dental implant. So let me finish with this challenging case I would like to share with you. This is Mark. Mark came to see us about 8 years ago. And at the time, he had a failing post-crowns bridge. So 3-unit bridge supported with 2 post crowns. His dentist asked me to remove the bridge and put an implant in the middle because the dentist felt that these 2 post crowns can be successful if we remove the loading of the middle pontic. And that's what I did at the time. We just sectioned the bridge and placed a dental implant for Mark. This sort of design lasted for a good 7 years, after which Mark was referred again to me by his dentist, saying that the 2 post crowns now failed furthermore. And now Mark wanted me to replace everything with dental implants. So we had so many options here. Option 1, to remove the 2 post crowns and put 2 more implants. But we know we don't really need 1 implant per tooth, especially in the anterior region. So it will be more aesthetics to have some pontics designed in this bridge. Ideally, I would like to have the middle as a pontic, but we've got an implant in the middle. So we decided to put an implant in the central incisor on the left-hand side and leave the lateral as a pontic. But then the second dilemma was what timing scenarios we're going to go through. And here we decided to go through the staged approach to give the body time to heal and reduce the amount of bone loss. What do I mean by that? We decided to leave the lateral as it is for now and focus on the central. So we decided we're going to take the failing post-crown in the central incisor. But we also thought about the temporary. We know that you could put a denture there, but that will give you more pressure on the soft tissue and the bone and will give you more bone loss. So ideally, we would like to have a fixed temporary. In this case, we have an implant. So we thought, let's have a 2-unit cantilever temporary bridge supported by that implant. And that's what we've done. We prepared this cantilever bridge even before taking the tooth out. We took the tooth out gently and we wanted to play it safe. We said, we're not going to go for immediate because we have high expectations here. So you could see that's the implant screw retained final crown, and this is the extracted socket. I would like to draw your attention how at the beginning we had that convexity and we managed to build that implant 7 years on, maintain the convexity because we did the bone grafting as we already talked about. This is our 2-unit temporary bridge, screw retained, and everything fitted nicely. Why this is important? Having a fixed temporary will get us better soft tissue healing and will give the patient a chance to understand the challenges involved, and it will show the patient how things will start to resolve. We left it 8 weeks, as you could see from the X-ray. Things started to heal, and that's at the time of the implant surgery. We removed the temporary bridge. Now, we lost some height of the papilla in between, and that's expected because the moment you take a tooth out, the papilla is going to lose part of its blood supply, parts of its connective tissue, parts of fibers. So it started to resolve. But another finding, although it's been only 8 weeks, you could see how we start to get some concavity at the missing tooth area compared to the other implant site. And obviously that is something also expected. Now, I wanted here to show you how the papilla was very shallow. So we decided to not disturb the papilla on both sides. We did what we call papillary preserving flap. Because on the lateral tooth, you could see there is bone loss. So if I raise that papilla, things will shrink because we have bone level more than 3 millimeters. So the bone sounding, the biological width was very far away. The bone sounding was more than 3 millimeters. If you raise that papilla and suture it back, it's going to reestablish its biological width and will follow the bone, and we're going to have ugly lateral incisor with exposed cementum, which wouldn't be nice. And the papilla between the 2 central incisors is basically supported by very weak fibers around the implant. And if we raise that papilla, we would have had more recession and maybe even exposed implant threads, which we didn't want that. So we preserve the papilla. We use our prosthetic surgical guide to show us where to place the implant. And in this case, I'm here showing you that the implant needs to be in the middle of the zenith, but the depth of the implant needs to be 3 millimeters away from the future gingival line. So we're going to place the implant even above the mid-labial area, placing the implant within the cingulum region in a taper implant, and that's where the implant stops. And you could see here, I'm comparing it with the adjacent central incisor implant. That's my implant, the new one compared to the older one. And you could see here we have some exposed threads. Now, I was comfortable with this because mesiodistally I've got some bone height, and this will provide the stability and the blood supply to my future bone. First layer, as I said, we use autogenous bone, and then we put a membrane. In this case, we use mucoderm, which is also a soft tissue graft and a membrane stabilized with 2 pins. And then we put a healing abutment, non-cover screws. Second layer going to be xenograft, build a nice convexity up to the level of the healing abutment, and then pull that mucoderm and suture it to the other side, and have some even more stabilization sutures, because stability is an essential feature of successful guided bone regeneration. And then we use the healing abutment to support the membrane, to tent it just like a post will support the umbrella cover, and then stitch everything nicely together and put that temporary back. As you could see here, we even overcorrected the soft tissue, and even we had to shave the temporary bridge tiny bit. We left it for 12 weeks. That healing abutment will start to self-expose itself while still supporting the bone graft. And then from there, we took an impression, but this time of the 2 implants, to give us a 3-unit temporary bridge. Because now we're gonna have that lateral tooth extracted. But because we're gonna extract it, we want to have some good time for the soft tissue to remodel. We cannot go for the final restoration. We had to go for a temporary. And we customize our impression pickup. And we had a 3-unit temporary bridge made. We took the lateral failing post-crown out. Okay. And as you could see, we've got the socket. We put some xenograft material because in the socket to preserve the ridge long term. I'm not planning to put an implant there. Hence, I don't have a problem putting xenograft into the socket. It's going to only be there to support the contour of the pontic area. And then we put a soft tissue graft, and then that's my 3-unit temporary bridge fitted. And these are the X-rays. We left it for about 12 weeks to get good soft tissue maturation. If you look at the X-ray, you could see how the xenograft filling the socket of the lateral incisor. That's my screw retained temporary bridge. We removed it, and you could see now we've got a nice contour. The zenith of the 2 centrals matching, some sort of papilla in between. Patient decided to have the other lateral prepared, so we did preparation, minimum preparation to have a crown, temporary crown fitted, wait for things to heal, and once we reach a point when things are good, we took the final impression for the final bridge, and things start to look acceptable. Now, this is a case where if we've done it all together as one stage, we could have lost lots of vertical bone and gum. So stage approach was important. And you could see we used the fixed temporization, which helped us at more than one level. But also, it was important to choose the right type of bone for the right indication. And this is the post-op CBCT showing the socket of the lateral nicely filled, and the older implant, which was placed about 8 years ago on 1-1 position with 2mm bone thickness, and the new implant, which was placed 2 years ago with 2.4 thickness of bone. Everything is stable, and we managed to get a screw retained bridge. I hope you found it useful. Thank you very much for your kind attention and for joining us in this nice webinar. Once again, thank you for all my friends who supported us at Baird Academy, and please go and visit our website to check our activities. And if you have any questions, you can email me at education@baird.uk.com. Finally, last but not least, I would like to thank my good friend at Dentistry Online Facebook group, Dr. Mazen, for his kind invitation. And I hope you find this short webinar a useful guideline for your clinical practice in implant dentistry. Wishing you all the best, and please do visit me at my Instagram account, Hassan_Maghaireh, to give me your feedback and any questions you have, as you know, nothing is better than communication between each other. Have a nice day. All the best.